Pleasure to be with you today to speak within the activities of the 18th DONIAT Cardiovascular and Diabetes Conference, and I would like to thank the organizing committee, especially Professor Ashraf Talat, Dr. Ibrahim Sabri, for giving me the opportunity to be with you today to speak about diabetes and kidney disease. I like this title, and you'll find a series of presentations about the diabetes and kidney disease. The most updated two presentations for me regarding this topic was on last January and March about the update of diabetic kidney disease and sodium glucose transporter 2 inhibitors. Today I'm going to continue this series by discussing the most important points regarding diabetic kidney disease. So I'll start with pathogenesis, presentations, the pathology and its impact on the management, pharmacology, the outcome and the renal replacement therapy to treat end-stage diabetic kidney disease, and finally a few words about precision medicine and conclusion. Hyperfiltration is a well-known important points in the diabetic kidney disease, and this is a very nice review discussing the mechanisms, clinical significance, and the treatment of hyperfiltration. The question, why hyperfiltration? Because diabetes stimulates the nephrons to work maximally. So why there is hyperfiltration? Because usually we have a residual and reserve in the kidney function that is utilized maximally. At the end of this maximal utilization of the kidney with high GFR, ultimately GFR will decline. So if you look here, even after the end of the hyperfiltration phase, you'll find here the nephron mass is diminished, reaching 50%, and still the GFR was a normal. If we look at this figure, part of the figure, you'll find here the GFR is 120 ml/min. All at this starting from this point to that point. But if you look here, the GFR is 120 ml/min, but the nephron mass, 50% of the functional nephron mass is lost. So if we know well how to start and how to tackle the issue of hyperfiltration, it gives us the opportunity to protect the kidney. First of all, hyperfiltration occurs if the hydrostatic pressure increases within the glomeruli. How the hydrostatic pressure increase? We know that the blood is coming to the capillaries of the glomeruli from the afferent arteriole. If the afferent arteriole is dilated and the efferent arteriole is vasoconstricted, normally there is a disparity of the lumen, so afferent arteriole is more wide than the efferent arteriole, and this keeps positive pressure in the hydrostatic pressure of the glomeruli to maintain GFR. But what happens in the hyperfiltration? There is more and more afferent dilatation and more efferent constriction. Why this occurs? Because of factors. These are the factors causing an introduction of the afferent arterial resistance. This means afferent vasodilatation, either vascular factors or tubular signals. Vascular factors include nitric oxide bioavailability, COX-2 prostanoids, kallikrein kinins, ANP, angiotensin 1 to 7, hyperinsulinemia per se. And tubular signals like inhibition of tubuloglomerular feedback, macula densa signals, because in type 2 diabetes there is increased expression of sodium glucose transporter 2 in the proximal convoluted tubules, leading to increasing the reabsorption of glucose, and with the glucose increasing reabsorption of sodium. This means that the level of sodium reaching the macula densa is reduced, and this leads to imbalance of the tubuloglomerular feedback, leading to afferent vasodilatation. The second part is more and more efferent vasoconstriction. So the factors causing a net increase of efferent arterial resistance. This means more and more efferent vasoconstriction. Through these factors, increasing more and more angiotensin 2. Usually we need angiotensin 2 because angiotensin 2 leads to the hydrostatic pressure because it keeps efferent constricted in relation to afferent arteriole. But here angiotensin 2 is very high. Thromboxane A2, endothelin 1, and reactive oxygen species, all these issues lead to more and more afferent dilatation and efferent vasoconstriction and leading to hyperfiltration. If we know well how to tackle hyperfiltration, starting earlier in intervention of diabetes from the early beginning by changing the lifestyle, optimal management, this will help to protect against hyperfiltration and its consequences. One of the important points in the pathogenesis is metabolic memory. Why there is a metabolic memory? Because a lot of issues like advanced glycation in the products, oxidative stress, epigenetic, histone, DNA methylation, etc. All these mechanisms lead to the end station, which is hypoxia. And currently there is shifting paradigm to think of hypoxia and treating hypoxia. So prolyl hydroxylase inhibitor with classes of drugs which are used in management of renal anemia, there is the thing to use them to target hypoxia, to manage the metabolic memory. Another pathway which is oxidative stress, and how to use bardoxolone methyl to reduce oxidative stress, and we know that this drug can affect the heart. So there is ongoing clinical trial phase 2 in Japan, putting in consideration the issue of heart failure and to address the role of this drug in reducing oxidative stress and to adjust the metabolic memory. If we look at the glucose toxicity, these are the mechanisms beyond the glucose toxicity, increasing inflammatory markers like in nuclear factor kappa B, MAP kinase, and TNF alpha, and the inflammation, increasing reactive oxygen species, renal injury, and all these mechanisms are inhibited by hydrogen sulfide. So hydrogen sulfide may be a renal protective and a friend for kidney. If we think of hydrogen sulfide gas, it is a toxic gas that can lead to even paralysis. How to use it? It is very dangerous to use inhalation of this gas, but if we use a friend source of hydrogen sulfide donors, and you'll be surprised that garlic, this is the product, and this is the garlic. The garlic is one of the generator of hydrogen sulfide. But the problem, we don't know how much garlic to be consumed every day to create a good amount of hydrogen sulfide. Another point is sodium thiosulfate that is used for treatment of calcifluxes. But the problem is sodium thiosulfate should be given parenterally because they are destroyed by the gastric HCl. How to create sodium thiosulfate in a capsule resistant to HCl? This is another thinking paradigm. And there is a phase 1 clinical trial of using SCG 1002 as hydrogen sulfide donor, and we are waiting the results of the hydrogen sulfide in these issues. How diabetic kidney disease is presented? It may be, all of us know the diabetic nephropathy presented with, the patient presents with edema, proteinuria, etc. But today I'm going to speak about silent diabetic nephropathy. This means that nothing, there is no clinical presentation, the process is working. So if we put in our mind this issue and this concept of silent diabetic nephropathy, this means that we should target diabetes from early beginning, and even we may think of prevention of diabetes itself. How to diagnose silent diabetic nephropathy? Maybe by the use of biomarker, but still we are not convinced for the practicality of using the multitude of biomarkers. Another point from the advances in radiology is MRI techniques using arterial spin labeling MRI, because this technique of MRI is able to detect early hemodynamic changes in diabetic nephropathy by evaluating the renal blood flow. Here, if you look at the normal control, even if you look at the visually at this figure and comparing A versus B. Here, this diminished renal blood flow by 100 gram of renal tissue. And if you look here, in comparison to normal control, the diabetic patients, even if there is no clinically established diabetic nephropathy, there is a reduction of renal blood flow milli per minute per 100 gram of renal tissue. And this is the more the worsening of the GFR, the more the reduction of renal blood flow. So this means that we can even diagnose the reduction of renal blood flow in the early phases of silent diabetic nephropathy, and even the role is more manifest with advanced chronic kidney disease. Another point which is very important, we should look at the follow-up of the patients, looking at the trajectory of serum creatinine or the trajectory of the GFR. This means that we should always keeping eye on patients, because the progression of the kidney disease is different from a person to a person. So we may have patients with very fast progression, moderate progression of kidney disease, and slow progression of renal declining. How to define? By the slope and the reduction of GFR. If the GFR is reduced by more than 50 milli per minute per year, this is a very fast progression. Fast, below 10 milli per minute. Moderate, 5 to 10, and below 5, it is the slow progression. The degree of progression predicts the occurrence of end-stage kidney disease. If the patient is within the very fast progression style, here we can expect occurrence of end-stage kidney disease between 2 to 5 years. But if the patient is within a slow group, the progression to end-stage may take a very long period, between 20 to 45 years. So if we can change a very fast progressor to slow progression, or even to prevent the progression, this may be the most important point. One of the important item is how to improve the design of randomized control trial. And here, according to the Joslin diabetes in type 1 and type 2 cohorts of patients, they find that the TNF receptor 1 above 4.3 nanogram per ml is a very important criterion predicting the progression toward the end-stage kidney disease. And the TNF receptor is between 2.9 and 4.3. We need another parameter like albumin creatinine ratio exceeding 1.9 gram per gram creatinine. So either to use only one mark, like which is TNF receptor if it exceeds 4.3, or to use two markers, TNF receptor between 2.9 to 4.3 plus albumin creatinine ratio exceeding 1.9 gram albumin per gram creatinine. Another interesting point is the total bilirubin within normal range. If we have a person with serum bilirubin 0.9 milligram per deciliter, another 0.4 is 5, and the other person 0.2 milligram per deciliter, which is more risky for progression of kidney disease, you will be surprised. Persons with very low levels of total bilirubin are risky persons, because normally serum bilirubin is one of the defense mechanisms against oxidative stress. If you find an adult with very low level of serum bilirubin, this means that this person has very high level of oxidative stress that may predict the progression of kidney disease. So we should aggressively deal with the lifestyle modification of these patients, because we are predicting the more progression in these patients with very low level of serum bilirubin. Another interesting point here, the impact of the presence of chronic kidney disease in diabetic patients amenable or subjected to percutaneous coronary intervention in the era of new generation drug-eluting stents. Here they looked at these 3 generations of newer generation drug-eluting stents: biolemus eluting, everolimus eluting, and zotarulimus eluting stents in these 880 patients. Here, the most important point is the presence or absence of chronic kidney disease, because presence of chronic kidney disease predict patient-reported outcome like mortality and occurrence of myocardial infarction. So, presence of chronic kidney disease in the diabetic patient is bad news. And even we may find a very catastrophic presentation like calciphylaxis of the penis that necessitated this partial amputation of the penis. Here the CT without contrast shows the presence of vascular calcification, so it is very rare. So yes, we all of us know the common presentation of diabetic nephropathy, but today I just updated this presentation from silent to catastrophic points and to put the issue of diabetes in our mind. Regarding pathology, this is a very alarming, interesting data. If we look at the data, this is the large number of patients with glomerular affection and a biopsy-proven glomerular disease. What can you see? The sector of diabetic glomerulosclerosis is increasing all through these decades from 5.5% to 11.4 to 19 percentage, to the point that the editorial comment was the temporal trends and epidemiology of biopsy-proven glomerular diseases, an alarming increase in diabetic glomerulosclerosis. And this is another study showing the issues of pathology in diabetic kidney disease. The classic pathology is diabetic nephropathy, and how the American Society of Nephropathology looked at the diabetic nephropathy is the classic pathology that they first assess the tissues of diabetic patients. Is there global sclerosis? So it is stage 4. If there is no global sclerosis, is there nodules? So this is nodular sclerosis, stage 3. If there is no nodule, there is mesangial expansion, and mesangial expansion is further evaluated to less than 25% to A, and above 25% of mesangium is expanded is to B. If there is no mesangial expansion, the class 1 or phase 1 of diabetic nephropathy is to measure the thickness of basement membrane. If it's exceeding 390 in women or 400 in men, this means that the mesangial basement membrane is thickened. So these are the classic pathology of diabetic nephropathy: basement membrane thickening, mesangial expansion, nodular sclerosis, and lastly the global sclerosis. This cohort in this cross-section study, they looked at the classic pathology. If there is classic pathology, this is a diabetic nephropathy. If there is non-diabetic renal disease like superimposed membranous nephropathy, minimal change, post-immune crescentic glomerulitis, etc., and or the presence of cocktail of diabetic nephropathy with this superimposed non-diabetic kidney disease on top of diabetic nephropathy. Here, the 5-year renal survival is adversely affected by the presence of the pathology. So diabetic nephropathy, classic pathology, is bad and predicting poor survival of the kidney after 5 years. But the non-diabetic renal disease in a diabetic patient attaining better survival. Why? Because we can modify the natural history of non-diabetic renal disease by giving specific treatment for these patients. And here, the most important point in the determining renal survival is the glomerular affection. So this is the point. If you ask me what are the classic indications for doing a biopsy in diabetic patients, presence of macrohematuria means macroscopic hematuria, presence of systemic disease, rapid progressive renal failure, persistence with the presence of nephrosis syndrome despite normal creatinine, because we can expect superimposed minimal change or membranes on top of these patients. But if you are within the group who like the biopsy, it will be fine, because at the end of the day it gives a good idea about the presence of superimposed non-renal non-diabetic kidney disease, and even it give a snapshot for the renal tissues that can give an idea about the prognosis. This is an example. This electromicroscopic appearance of non-diabetic kidney disease. If you look here, this is the endothelium and endothelial cells, endothelial side of the basement membrane, epithelial side. What do you see? This is the deposit, either subepithelial like this or intramembranous. So this is the classic membranous nephropathy in diabetic patient. Regarding the treatment, we should be smart in using medications, using anti-diabetic drugs, because according to the FDA, for metformin is the best drug for management of type 2 diabetes because it's very cheap with good pharmacological points, because it has cardiovascular protection, nephroprotection, etc. But the most important point is the presence of kidney dysfunction is a major limitation for the use of this drug, because in the FDA regulation and recommendation, if serum creatinine exceeds 1.5 in men or 1.4 in women, here they recommend stopping and discontinuing metformin. And even the European guidelines and the KDIGO guidelines, both this values of estimated GFR. If estimated GFR between 60 to 45, we can use it cautiously. But if it is dropped below 30 milli per minute, we should discontinue according to the European guidelines. But regarding the most updated information, can we use metformin in advanced CKD? This will that I'll discuss after a minute. Sulfonylurea, we should know the drug that we are using and its modification, because long-acting sulfonylurea, especially with active metabolite like glibenclamides, should be avoided in the presence of well-established chronic kidney disease. And other drugs needs modification according to this leaflet. And these are the other drugs. Here, bioglitazone needs no dose adjustment. However, we don't like to use it in chronic kidney disease because we are afraid of volume overload by using this drug, because it leads to salt and water retention. Here's the question: could metformin be used in patients with diabetes and advanced chronic kidney disease? The answer, according to this study and this discussion from the review, is yes, we can use very small dose, down to 500 milligram per day, because it can add a lot to the patients. But be careful. Here they discussed in this review 2 points: to consider metformin drug level, and either to use cut point 10 milligram per liter or 5 milligram per liter according to the Chinese experience, and this 5 milligram per liter coincide with 500 milligram total dose per day. And the second point is to use the modified or extended release formulas of metformin. So if we are dealing with advanced chronic kidney disease, we should use the lowest dose. And here, regarding the level may be costly and may not be an excellent predictor of lactic acidosis with metformin. But the most practical way is either to avoid the use of metformin according to the dogmatic guidelines, or to use the lowest dose, 500 milligram in advanced CKD and on dialysis, and put in consideration and educate the patient to stop and discontinue metformin in the sick days, sick rule use of metformin. So if there is vomiting, nausea, fatigability, in these days, stop metformin because we are afraid of lactic acidosis. And this is another accepted manuscript they addressed in this study of limited number of patients, the pharmacokinetics of using different dosages of the metformin: 250, 500, and 100 milligram of metformin in stage 4 diabetic nephropathy. Another point is incretin mimetics. Incretin mimetics are friend for the kidney because they cut all these mechanisms that can lead to progression of kidney disease, hyperglycemia, dyslipidemia, inflammations, a lot of issues. So by cutting all these pathways, they prevents progression. But the most important concept that I addressed in the previous versions of my presentations, the context-dependent effects of dipeptidyl peptidase 4 inhibitors. This issue is we have these peptides, chemokine full length 1 to 68 and neuropeptide Y 1 to 36 agonists. And these peptides, chemokines and neuropeptide Y, are metabolized by DPP4. So if we block DPP4 by using DPP4 inhibitors, we will keep these peptides. So again, DPP4 inhibitors are essential to keep incretins, and incretin is protective for the heart and for the kidney. But if we stop the metabolism of these chemokines, we will keep them. If they are low by default, because the persons are categorized into low activators and high activators. If you are dealing with high activators, this means that the full length of the chemokines and neuropeptide Y are high and active. And if we inhibit their metabolism, we keep them very active. So they work on the receptors on the heart, stimulating cardiofibrocytes and leading to heart failure and renal dysfunction. But if we are dealing with persons with low activation, low concentration of the full length of chemokines and neuropeptide Y, using DPP4 inhibitors will keep incretin high. This means that incretin here will outweigh the risk of chemokine and neuropeptide Y. So if either we measure chemokine and neuropeptide Y and know that the level is low, at this point DPP4 inhibitors are friends, or the chemokines and neuropeptide Y are high, and if we block their metabolism, we will keeping these devils that can lead to heart failure. So at this point, DPP4 inhibitors are not friends. And keeping in mind their friendship, we may use them plus chemokine receptor blockers and neuropeptide Y receptor blockers. So this is the changing paradigm in the concept. Regarding sodium glucose cotransporter 2 inhibitors that inhibit sodium glucose cotransporter 2 within the proximal convoluted tubule, leading to glucosuria and natriuresis. We have these agents in the class: dapagliflozin, canagliflozin, empagliflozin, and a lot of gliflozin, as you see here. Always, every day, there is a newcomers for this class. So this is really a new additive. And this cartoon shows how they work, how they are friend for the kidney, how they are adjustable glucose feedback. In type 2 diabetes, as I mentioned in the beginning, there is increased expression of sodium glucose cotransporter within the proximal convoluted tubule, with subsequent increasing reabsorption of sodium and glucose. So sodium reaching this macular density is reduced, and this leads to imbalance of tubulo-glomerular feedback with the subsequent afferent dilatation and efferent spasm, leading to hyperfiltration. Using sodium glucose cotransporter 2 inhibitors lead to adjusting and decreasing sodium reabsorption, so sodium will reach the macular density and restoring tubulo-glomerular feedback, leading to afferent constriction and efferent dilatation and the reduction of the hyperfiltration. So this is a very friend. Here just 1 or 2 points in this class. If estimated GFR is drastically reduced, the effects of these drugs on A1C is reduced. So to use these drugs to be friends, we should use them with in early phases of diabetic kidney disease with preserved GFR. So here, if estimated GFR is less than 45 ml per minute, the major drugs in this class should not be used. And again, we are waiting. We have Empiric outcome trials and nephropathy trial, and the Empiric outcome shows that empagliflozin is nephroprotective, and there is another study on canagliflozin, but we are waiting this study that is completed in February. But still, we are waiting the results of this study because it included 5,800 patients from 420 sites in 24 countries, and will give us an idea about the efficacy of this class of drugs on protecting the kidney disorders. Again, we should know how to use these drugs. So it's better not to use them in case of dehydration. And if we add ACE inhibitors, we should monitor kidney function well. And we shouldn't give them to patients with reduced GFR and for the presence of active UTI. And we should monitor the patients for nausea, vomiting, and fatigability that may refer to ketoacidosis. So we should put in mind to monitor for ketones because they may lead to euglycemic diabetic ketoacidosis. And the most important point is the cost. So we shouldn't start management of type 2 diabetes by using sodium glucose cotransporter 2 inhibitors, but we should start with metformin. So giving metformin if the patient, if the metformin is inadequate and still we need a second drug, so we can use sodium glucose cotransporter in these scenarios, or if there is intolerability to metformin, so we can start with sodium glucose cotransporter 2 inhibition. A very interesting and smart question from the update. Can we use sodium glucose cotransporter 2 inhibition as a renoprotective against non-diabetic chronic kidney disease? This is an experimental study done in rats. The rats were fed on high oxalate leading to chronic oxalate nephropathy and the chronic kidney disease. And here, studying sodium glucose cotransporter 2 inhibitor in the rats showed no difference. So it is better not to use. So there is no evidence to use sodium glucose cotransporter 2 inhibitors outside the domain of diabetes. And here I want to stress on they are approved only in type 2 diabetes, not type 1 diabetes yet. Regarding hypertension, this is the most updated information about the treatment of hypertension in a diabetic patient. So the guidelines here. Persons with diabetes mellitus should be treated to attain systolic blood pressure less than 130, and this is a grade 3C, and diastolic less than 80, and this is a grade A. These target blood pressure are the same as blood pressure treatment thresholds. A combination therapy using 2 first-line agents may also be considered as initial treatment of hypertension. And this is a grade B recommendation if systolic blood pressure is 20 millimeter mercury greater than target, or if the systolic blood pressure is 10 millimeter mercury greater than the target. However, caution should be exercised in patients in whom a substantial decrease in blood pressure is more likely or poorly tolerated, like elderly patients and patients with autonomic neuropathy. This means that the reducing blood pressure to less than 140 and in systole and less than 90 in diastole, and to monitor the occurrence of adverse points. And the last guidelines in 2016 showed that we shouldn't reduce systolic blood pressure less than 120 because this will lead to more intolerability, side effects, and even renal outcome profile. If we selected this tight controlled blood pressure, we should monitor the patient adequately and seriously, searching for adverse events or signs of intolerability. And I think the patients who will get the benefit of tight controlled blood pressure, those with family history of stroke. For persons with cardiovascular or kidney disease, including microalbuminuria, or with cardiovascular risk factors in addition to diabetes and hypertension, using ACE inhibitors or angiotensin blocker, this or that, not combination of them, is recommended as initial therapy, and this is the grade A evidence. For patients with diabetes and hypertension, not included in other guidelines in this section, appropriate choice include in alphabetical order ACE inhibitors, grade A, ARBs, grade B, diarrhythmic calcium channel blocker, grade A, thiazide-like diuretics, grade A. However, when we start the combination therapy, it's better to use dihydrobiodine calcium channel blocker with ACE inhibitors or ARBs is superior to the use of diuretics. Finerenone, this is a mineralocorticoid receptor blocker, non-steroidal mineralocorticoid receptor blocker with added benefit of the less risk of hyperkalemia. Regarding the outcome, this is a very nice study looking at 6,000 patients, and the patients were followed up for 2.3 years, Death occurred in 900 patients, end stage in 200 patients, and this to correlate association. Here the green zone, the green area is within this limits of hemoglobin A1C, 7 to 9. But if the hemoglobin A1C is lower, less than 60% or above 9%, mortality increases. This is just to give an idea about to use A1C. So in chronic kidney disease, we think of if chronic kidney disease is established and creatinine is high and the estimated GFR is less than 60 milli per minute, we may think of selecting A1C around 7%. And if the patient experiences any hypoglycemic episodes, we can even be more relaxed, reaching up to 8.5% to avoid the risk of hypoglycemia, because our priority in established chronic kidney disease not only to strict control of diabetes, but the highest priority is to avoid the hypoglycemia. So the relationship of A1C to mortality is following the U-shaped curve. If it is less than 60% or above 9%, mortality is increased. Again, hypoglycemia is very important. It's a very nice study, including a large number of patients. No hypoglycemia in 16,000, one episode of hypoglycemia in 3,000, and more than one episode in 1,000 patients. Here you can see if there is hypoglycemia, mortality increases, and if the hypoglycemia is repeated, mortality even doubled or tripled. So we should be careful about hypoglycemia. Even in the more risky persons, in elderly person, hypoglycemia is very prominent. Here, if you look here, by using anti-hyperglycemic therapy, if estimated GFR is preserved, the incidence of hypoglycemia per 10,000 is minimal. But if estimated GFR is drastically reduced, here there is a tenfold or more increase in the incident rate of hypoglycemia. Even striking news, even if the patient doesn't receive anti-hyperglycemic therapy and estimated GFR is very low, here there is a risk of hypoglycemia. So should consider advanced chronic kidney disease as a risk for hypoglycemia, and to put in mind. Regarding renal replacement therapy, is it wise to start dialysis earlier in a diabetic patient? Because this was an old dogma to start the dialysis earlier. The answer from the systematic literature review is no difference between diabetes and non-diabetes regarding the onset of starting dialysis. And what are the type of renal replacement therapy? If we think of dialysis, is it mandatory to start peritoneal dialysis like the old dogma? The answer is no. We should discuss with the patient different preference and the available modality, and the patient may select PD or hemodialysis. And if hemodialysis is selected and chosen, it is better to think of high flux dialysis, because there is a lot of data about the superiority of high flux dialysis over the low flux dialysis, but still the evidence for hemodiafiltration is lacking. So these are regarding the dialysis. Regarding transplantation, for type 2 diabetes, kidney alone transplantation is recommended. And if there is living donor kidney transplantation, this is the best in treating end-stage kidney disease and diabetes. No role for pancreas transplantation or islet cell transplantation type 2 diabetes. Regarding type 1 diabetes, if there is no living donor, the best treatment is combined liver and kidney if the general condition is fit for pancreas, because pancreas transplantation needs a high level of fitness. So we shouldn't wait if the patient has live related donors. So living donors is superior even in countries with cadaveric program. If the patient comes with a donor, we proceed for kidney alone, and then to assess the comorbidities. If there is no comorbidities, we can allocate the patient to cadaveric pancreas later on after the kidney transplantation. If there is no living donor and the patient condition is fit, we can put him on the list of combined kidney and pancreas later after the available of the donors. To close the presentation, today we are depending on serum creatinine, proteinuria, and sometimes the biopsies for the kidney tissue. So this is the current management style. But in the future, when we think of the genotype and studying the omics and the bioinformatics, this will change our mind to individualized treatment, to select the best treatment for specific individual. So this may be in the future. Still, we are needing the more studies and searching for the less costly management. And this is the study of different proteins. These are 17 proteins that correlates with the outcome of the different stages of diabetic kidney disease, either uncomplicated, incipient, or over diabetic nephropathy. And the proteins, they can be put in a map like this, giving the fantastic bioinformatics, telling us about the style of the patients and on the molecules, activation, inhibition, etc. So this will be in the future. But one of the good news is this new decreasing incidence of interstitial disease in American Indians with diabetes, a model for other high-risk population. Why? Because they addressed what happens, what the change, what occurred in the management for these patients. The management is changed toward multifactorial intervention, starting earlier, addressing the all lifestyles like exercise, salt restriction, lipid control, blood pressure control, management of diabetes from the early beginning. All these can help a lot. And if we compare following the multifactorial intervention versus traditional one, here the incidence of chronic kidney disease is drastically reduced if we follow the multifactorial intervention. So if we so this is I think this last slide. We are what I want to say is we should change our mind toward the prevention, because prevention is superior to treatment, and it's better, as said, prevention is better than cure. How to prevent is to prevent diabetes if we can, and we should change our lifestyle from sedentary to exercise, salt restriction, high fiber diets, targeting lipids, glycemic state, and all these. So we need good education of the patients, good education for doctors, health care system, follow up, and we are waiting a lot on a lot of research. And I think research carried out at Urology Referral Center and led by Professor Onaim and his fascinating team, Professor Ayman Rifai, Mahmoud Gabr, and other members in the team, is very fantastic. And this is Roy Khan. So we are waiting the result of this research, and maybe in near future we find solution for diabetes. Thank you for attention, and if you have any question, please send it to my email. Thank you very much.